Hello, dear colleagues. How are you? My name is Mynzhylky Berdikhojayev, my assistant Rawan Maratlı, and Pooja Dugani. Pooja from India, we are from Kazakhstan. This is a presidential hospital, national hospital in Almaty. Almaty is the previous capital of Kazakhstan. And now we have a patient. Patient is 65 years old lady, right? Yes, young lady, 65 years old. And Rawan Maratlı made an angiography. Patient has aneurysms on both ICA. This is biggest one, and previous one was smallest. I think we will place FD. The segment is diseased, and I think it's better to place a flow diverter stent. Менің кем қай жағында? Оң жағында ғой, да? Сол жағында ғой? Yes, and patient has a meningioma, falx meningioma on the linker Seite, on the left side. And okay, let's check. It's facial artery. This is a meningeal artery. It's a intra-superior sagittal sinus meningioma. Yes, I'm not sure. Many neurosurgeons will try to resect this meningioma. Yes, it's very dangerous location. And okay, let's check the patency of sagittal sinus. It's very important when you plan the meningioma treatment. And it looks like there is some obstruction, and there is a collateral venous outflow. That's why I think it's quite symptomatic meningioma with the mid-sagittal sinus occlusion. Okay, let's see the 3D. First of all, I would like to check the right side. Just a second. Right side, and then we will check the left side. For me, the important side is left side. The right side looks like just the beginning of the aneurysm. It's a irregularity, and we can follow this aneurysm. It's just the beginning of the aneurysm, yes? Maybe it's just irregular ICA. Let's count it like irregular ICA. And this is more aneurysm on the left side. Okay, the plan is, it depends where now Rawan Maratlı is located with the guiding catheter. He is in external carotid. I think, yes, the segment is diseased. There are two options. Option number one, to place a stent and coil. Option number two, just a flow diverter. Okay, I think we can place just a flow diverter. Patient on Berlinta, ticagrelor, local generic, and aspirin on dual antiplatelet. And I think this projection is better. Okay, we can start from meningioma, and then we can go to the ICA and place the stent. Yeah? Okay, let's start from meningioma. I will give a Traxess 14, and внутренний сон диаметр 0,6, төменгі жағын, аневризманың төменгі жағы. Okay, I'm asking Рауан Маратlı, Rauan Ayteli, to measure the proximal part of ICA. Yes, proximal part of the ICA. Just a second, maybe I will measure. Мен өзім өлшей саламын. Рауан? Okay, the segment is diseased, and that's why we prefer to place a stent. The stent is better, 6 millimeter, 5 millimeter. I think this segment is more accurate. 4.9, 4.8, and distal part is 4. And I think this part 5 millimeter. It's so big difference. Okay, maybe we'll place a Leo Plus stent with a couple of coils. It's also a possible option. This is 3 millimeter, 2.8. Okay, let's see which will be the better. Yes, patient has headaches, that's why the MR was done. It's incidental finding of the aneurysms. And this is the case number 2 for today. And then we have case number 3. Case number 3, patient with the ACOM aneurysm, a ruptured one, and the next patient was operated at the acute period, and the dome of the aneurysm, the ruptured point diverticulum was coiled, and he was bypassed in Astana Presidential Hospital. Then our colleagues decided нені бере салшы, шприцтер бере салшы, Менекстің шприцтерін. Менекс, сквит, қайсының шприцы бар? Шприц. Соны бере салды. И ДМСО жинауық. ДМСО. Yes, we have a couple of bottles of Menox and something. Айтқан кезде Menox ашып бересің, хорошо? Okay, let's go. And the next patient was bypassed. It was a middle meninge STA to ACA territory bypass, and he was planned for microsurgery or endovascular. Then colleagues decided to discuss with patient, and finally recommended to come to Almaty, and we are planning endovascular embolization of the ACOM aneurysm. I think it would be stent assist coiling. We will see. We will see in a couple of hours. Не зафиксировалось. Okay. And for this aneurysm, concerning the size of ICA is nearly 5. I think the better decision will be to place a Leo Plus and put 1 or 2 coils inside the aneurysm. And we'll see. Okay, this is for the. Just a second. It's a 2.5 cc syringe. Sorry, excuse me. Alpin. Dreams Alpin. Okay, now we are in the meningeal territory. Yes, we asked the engineers from service company to check the AP and lateral tube, and yes, we need to replace both tubes. Oh, there's fault. The name of this surah is Bakara surah. Yes, it's better to have a support from everywhere, including the support from the heaven. Okay. Okay. It's better to do it like this, a little bit. Yes, there's a different approaches, and the alternative for microsurgery, the risky microsurgery, is a gamma knife, but I'm not sure the gamma knife is a good option. And the radiosurgery may end with the stop. The radiation injury from gamma knife is also significant, and I'm not sure it's a good option. If it's possible to approach with the microcatheter and inject some liquid embolic, as our experience showed that един референсный шарт пересеш? Референсный шарт пересеш? Наружка с ним там. Yes, if it's possible to inject some liquid embolic and occlude the жоқ осыны назад келесі. Okay. Yes, it looks like we are in the correct position. Yes, if it's possible to selectively catheterize the meningioma, then why not to inject something very effective? And our experience showed that endovascular treatment of the meningioma is feasible, effective, and safe, effective and safe treatment option. And in meningiomas less than 3 centimeter, sometimes it could be the bigger sizes. It's possible to exclude from the circulation. Okay, now we are inside. Also, there is some scientific works from Buffalo, from Adnan Siddiqui and team and other colleagues. It's possible to inject some anti-angiogenetic medication, and it's also very effective. Okay, let's start to inject. Бересал, мен експресал. Или тратор, сквит пърма, сквит пересаш. Дексаметазон 12 мг. Yes, we will take a squid 12, which was on the shelf. I think it's enough. Okay. Yes, it's a nice alternative for the gamma knife. And the cost of the gamma knife in Kazakhstan is nearly $4,500 for each radiation session. Glue, ça? Okay. Berdikhojayev, poisson, t'as Jojo. Okay. Yes, for each radiation session is a 4,500. That's why endovascular embolization is comparable, and the effect of endovascular is quite fast. Okay, I think it's a collaterals from the ophthalmic artery, which were seen on angiography. Okay. We filled both sides, and right and left. Yes, at some point the tumor might rupture from inside, and it's a good sign to stop. Now we're filling the contralateral. Yes, it's okay. I think it's okay. It's from external part, the collateral. It's coming somewhere there. It's just a one microcatheter, one wire, and most of the time one bottle of liquid embolic is enough. I think now it's enough, and yes, the headway duo retrieval is also quite fast. And we'll look a little bit more. Okay. Let's okay. There's the bifurcation. Yes. Now we can take out the headway duo. Okay. Let's through it. Okay. I hope the meningioma is excluded from the circulation, and usually with protocol we are doing control MR in a couple of days with the contrast, and if meningioma became dark, then we can follow the patient, and usually in following months it's disappear. Okay. Yes, we can stop with meningioma, and now we will go for the yes, we have a 5mm Derivo stent. I think it's one of the options, and Derivo could be started from 4mm as the option number 1. Option number 2, we can place Leo Plus and coils, but then it's a little bit risky. Which option is better? Derivo? Derivo is better. Yeah? Okay, let's play Derivo. Headway 27. Міне, headway 27. Фен қоссың. И полкада Derivo 5 мм бар, соны бересің. Коробкасын болса айтшы. Да, аша бер. Жо-жо. Derivoның коробкасын. Жо-жо. Okay, let's prepare this. Келесеш? Маған размер керек. Yes, we can start from 4. Yes, Derivo 5. Yes, we have 5. Yes, он аша бер. Я примерно свой глад. Фен қоссың. Ашып сен. Ашып тастасың. Фен қосып жүрсің. Yes, the very active in meningioma embolization in India, my friend Rahul Kumar. He's injecting glue. Yes, and it's amazing work from Rahul. And now we are planning to conduct a trial. Or it will be just a paper on meningioma embolization. Rahul has big experience, maybe some of the other colleagues, and also Markus Hotman-Spotter from Nuremberg. And in Kazakhstan we have more than 300 cases. And nearly 100 is just embolization only treatment. Yes, and for embolization, we can go for the skull-based meningiomas, parasagittal meningiomas with the inclusion of sagittal sinus, and usually it's not problem. Yes, and with the gamma knife, there is a percentage of radiation-induced necrosis. That's why maybe endovascular option is could be good alternative. After preparation of the paper, it will be more than 500 cases, including India, Germany, and other countries' experience, and also my friend and Professor Tanaka, Michihiro Tanaka from Japan. He has several publications on meningioma embolization. Yes, it should be good, like subdural hematoma embolization. Nowadays, it's a good alternative for microsurgery. Yes, in some cases it's usually we do it under local anesthesia. But for this treatment, patient asked to give a general. Yes, and when patient is asking, we are following for the needs of the patient. Yes, if patient's scary, then treatment could be disaster. Okay, let's see. Guiding is in common carotid. Okay, let's see. It's external carotid. It's external carotid. Again, external. Rodno. Navigate. Okay, now it's okay. It's a usual problem passing the ophthalmic artery. That's why we gave angulation for the guiding catheter. Heparin 5000. Okay. Yes, the guiding catheter is Fubuki 7 French. Fubuki, right? Judkins right, yes. Judkins right coronary Hyperion, and introducer sheath is 8 French. We took a headway 27 and headway duo for meningioma, headway 27 for the. Okay, so let's do the maximum zoom. Yes, I prefer to place the flow diverter under the maximum zoom. Then it's visible. It's possible to do with the digital zoom, but for me physical zoom is more reliable. Yeah, this one. Okay. Yes, now it's better. Stop. Okay, I think if we can place the flow diverter from the PCOM segment, it's very nice. I prefer not to cover the PCOM. I think we just started at the PCOM segment. I'm just pushing the FD. Yes, and it's maximum opening. Okay. It's a quite long, 530, but the proximal part is 5. That's why we choose. Yes, the distal is okay. Minus also. Yes, the distal is just before the PCOM, as we wished. Yes, stent is fully opened. Now we will do a little bit massage and then we can finish the case. Yes, meningioma is excluded from the circulation. And now the aneurysm is stented. We can take some black tea. We can drink some black tea. Yes. Yes, the coffee is not like a tea. You can drink limited number of cups. But tea you can drink from morning till evening. Yeah? I think the same tradition. In Kazakhstan, same tradition like in India. Yes, we are tea drinkers. That's why in India there is a tea break. Yes, I like tea breaks. Masala tea. Yeah? Yes. Okay. Now Yes, the artery is a little bit bigger than FD, but I think it would be no problem. It would be no problem. Yes. It's in the straight segment, that's why it should be okay. I'm not sure it would be problem. Yes, it's well opposed to the wall of the artery. Mynzhylky? Yes, it's okay. Maybe. No, it's okay, it's okay. The distal part is okay, the proximal is okay, the ophthalmic artery is in place. I will ask Roland to do expert CT control, and then on minute number 15 we can do control angio. Yes, let's check the control CT. I will take out my audio. If everything is okay, you can see on the monitor, and on minute number 15, Rowan will show like this if everything is okay. Okay. Thank you for watching. Let's wait for the controls. It will take 12 minutes. Okay. Câte